we are going to be opening the next case, and I'm just going to click on this one here. So we just download all the images, and you can see that red line going right across the top. And then we're just going to look at the plain film first. So having a look at this plain film, I mean, they've got abdominal pain. That's the first thing to understand. They've definitely got abdominal pain, right? So it doesn't feel like there's much going on right at the moment. Let's have a look. Let's zoom in a bit, see if there's anything going on. Please feel free to throw in whatever you think may be going on. But bowel-wise, it doesn't look like there's very much dilatation going on. I mean, these look like these could be phleboliths, don't they? Yeah, oh, hang on, I didn't know I could make a full screen. These look like these could be flowless. Okay, we've got the urinary bladder that's probably sitting there, or maybe, I mean, it could be calcified fibroids as well, depending on the gender. But then you've got these sort of what looks like calcifications sitting over here, and they look quite spherical. Could it be a bone island? Could it be something to do with the hip? Maybe it could be some slightly hyperdense fecal material sitting within there. I guess you'd have sort of the descending colon sitting along that region there. Can't really convincingly say that I see any evidence of any bowel dilatation anywhere. And the liver and everything else looks okay. So, I mean, the only thing that we can really say at this point, for definite, that these kind of almost spherical lesions that are sitting over here. So this patient didn't get any better. So they needed to end up doing something else. So as usual, you kind of do a CT scan to try and see it. And I might have given the answer away already. But as you scroll through, we're scrolling through front to top. So first of all, what phase of imaging are we looking at? That's the aorta. It doesn't look as bright as the spine there. Fine, fair enough. Coming forwards, we can see that the portal vein sitting over here looks brighter than the aorta, so therefore there's more likely to be a portovenous image. There's a hyperdensity sitting over here, which is most likely to be an NG tube. You can see that sitting just within the proximal stomach there, so it doesn't really need to be expanded much more than that. So hang on. So then what you need to do is sort of scroll down. So let's just follow the rules. We go right from the very, very top and go all the way down to the bottom. And then kind of, hopefully something jumps at you. If it doesn't, don't worry. We're going to go through it all anyway. So let's go from the very, very top all the way down. Like this. Keep going, keep going, keep going, keep going, keep going, all the way down, all the way down, all the way down. Keep going, keep going, keep going, keep going, keep going, all the way down, all the way down. And then, for those of you that may see it, great. If you haven't, don't worry. We're going to go through it anyway in a kind of very systematic manner. So let's go from the very, very top. So first off, we saw the NG tube, and looking at the liver straight away, you can see some air sitting on one side of the portovenous system, and it's not on both sides, okay, and it's not within the portovenous system as well. So that's good, because if you had air within the actual vessels, you'd worry there's some sort of underlying ischemia. But like I was telling you earlier from the previous case, you can see how if there was intrahepatic duct dilatation, it would be on one side, because in this situation, it looks like there's air within the biliary tree, not fluid in the biliary tree. And you can see it's on one side, not both sides. So therefore, that's what the biliary tree would look like if it's got air within it. So this could be because this patient's had a previous cholecystectomy, previous sphincterotomy, previous surgery within the region of the gallbladder. So that's something to be like, okay, well, that could be what's going on. But so for those of you that did do that scroll through, you may have spotted that there is what looks like quite a lot of dilated small bowel throughout the abdomen. In fact, if you just kind of scroll through, so there's some dilated small bowel there. So let me just put my phone on silent. There's some dilated small bowel just over here as well. You can see that there's multiple loops of dilated small bowel. But then as you kind of scroll up as well, you notice that the gallbladder doesn't look quite right, does it? It looks a bit off. Where is the gallbladder? I mean, did they take it out? And as you come down further and further, you can see that gallbladder, which used to sit here, is still sitting there, but now there's like a defect. So do you remember with the last case, we had a defect somewhere else, but now we've got a defect on the medial side of the body rather than the lateral side of the body. The lateral side gave us a collection, and a kind of collection that was sitting in front of the liver, causing some scalloping of the liver itself. But in this situation, we've got a defect that's sitting on the medial aspect. But then as you kind of look at that, it looks like it's communicating with, some of the adjacent bowel. So therefore, you're worried there's some sort of fistulation or some sort of communication with the gallbladder and the adjacent bowel. So what bit of bowel is this? If we scroll up and down, you'll see that this is the stomach. That's where the NG tube was. That's sitting within the stomach. You're going around, you're coming up to the pylorus, the duodenum, first part of the duodenum, and then it was around there, wasn't it? Look, first part of the duodenum, there seems to be a connection between what used to be the gallbladder or is the gallbladder and the duodenum. Now, how do I know that this is probably not just a diverticulum? It's so embedded within the region of the gallbladder fossa. I mean, it's very unlikely that you're going to get one single diverticulum into kind of out pouches into that region. It just doesn't really happen. And so one thing to try and remember is that common things are common. And so therefore, you're not going to, it's very uncommon for a diverticulum to be sitting within there. More likely, this is a structure that's sitting that's now communicating with the duodenum. And as you can see, as you go further down along the first part of the duodenum, it looks a little bit dilated. Go beyond this area, which usually collapsed. Most of the time is very, very collapsed around this region. And if there is dilatation, it dilates later. And again, you can see that, it does feel like it's dilating a little bit later. Let's zoom out a bit. And you can see that as you scroll through, this all quite dilated. And, we just got to follow it. And then you can see some hyperdense material there. Are we worried? I mean, it looks hyperdense, doesn't it? Then you kind of scroll through that way. You're scrolling through. So your eyes are around somewhere around here. And you're coming up to this region over here, maybe. I'm going to just keep my mouse, keep following. Look, that goes that way, all the way that way. We're coming up to this region over here, all the way. So we're going upwards. Oh, connects down here, coming all the way down. Oh, and then look. Looks like 1, 2, 3 very spherical calcifications sitting within that region. We'll go to the bone window and they look very, very spherical. Laminated or lamellated is what they call it. So there's layers of this calcification on the outside, 1, 2, 3 at least, which does correspond to the previous image where we had the X-ray. If I just open the X-ray, wherever that's gone, over here, and put that there, you can see, look, 1, 2, 3. We'll come back to the CT. Let's do it on coronal, just to be sure we look at the same thing. Look, 1, 2, 3. So obviously, depending on the angle that the X-ray was taken, you've got this. So someone said it exactly right. Yeah, well done. And you've also spotted the height earlier. Well done. So yeah, this is exactly. So someone has said what it is, and what it is a gallstone ileus. This is a gallstone ileus. So basically what's happened is that the gallstones that were sitting within the gallbladder have been there for so long, it's probably causing like chronic inflammation. And as time's gone on, it's kind of resulted in fistulation between the gallbladder and the first part of the duodenum. Now, if we zoom in, I'm going to just show you, look, there's that defect there, but on a different view. Can you see that? Nice little defect there going like so, and those are the gallstones. So these gallstones have gone on quite a life journey. They've gone from here, this is all they've ever known, the gallbladder, and they decided to go on an adventure, and they've actually ended up causing a lot of trouble for this patient. And this is called gallstone ileus. And you won't really get a better picture of gallstone ileus than that. I mean, that is as textbook as it gets. And sometimes even the textbooks don't have as good an example of not only the plain film, but also the CT to go with it. So I hope that is useful for someone out there.